Welcome to the Java Cafe, Java fam.
Good evening, everyone. Good evening. As I usually start and say, today is Wednesday, February 28th, 2000, and I was going to say 28th, 2024. And you are here for a special edition of what I'm calling Your Healthy Java, a vital edition. We are here this evening through a partnership I'm grateful for, our first sort of event together with Vital Connections. You're going to hear more from their director of community programming. I think I got that right, and she will surely correct me. She's a friend and sister, an advocate, well known in this community, and a comms just guru, and just a wonderful sister that really is invested in this thing we call health equity. And so I would like to introduce to some and present to others Miss Ayanna Polk, who is going to come and give you a formal greeting. And I did get it right, Director of Community Partnerships.
Well, you said programming, but programming is a piece of it.
Okay. All right. Please go ahead, Ayanna. Introduce yourself.
Yes.
Our greeting. I'm so glad to have you here this evening.
Yes. First of all, I just want to say thank you to you, James. I will say James, Java with Jimmy Hill, for having us on, and you know, this being the first of many opportunities to work together. Like you said, my name is Ayanna Polk. I'm the Director of Community Partnerships for Vital Connections, which is a health equity nonprofit here in Boston. And our mission is to make sure that we're shifting the needle on what it looks like to promote health equity and have quality solutions for the neighborhoods and the people that need it most. So with our organization, we make sure that we're talking about the topics that you all care about, whether it's how to combat long COVID, because we know that folks are still getting sick today, how to access the healthy foods that we need, you know, healthy and safe movement and community wellness. And what does that mean for all of us when it comes to, you know, making sure that we don't, you know, get the diabetes, high blood pressure, and the things that, you know, we see in our communities all the time, especially when it comes to community of color. So every month we come together, and we've done them in a number of ways, and they keep growing and growing, but we have these community conversations where we bring everyone that's involved with creating a solution, whether it be that people in the healthcare system, community-based organizations, and community members that care, which is all of us, right? We all come together and talk about different health topics and see how we can come together and create quality solutions. Tonight, I'm really excited that James, I will continue to call you James.
That shows that I think we met May probably in the beginning, but that shows that we're good friends.
Yes, and we've worked together in many ways, but I'm really excited that we get to work together in this way, because I know, you know, with your Healthy Java and the number of the things that you've done in the community, I know I've watched your show to get connected to some of the solutions that I need. So I'm happy that now that I'm in the health equity space, we can work together to provide some of those thoughtful conversations and solutions. So tonight, we're going to be talking about restoring trust in healthcare, which is something really important to me. And I know we all have our lived experiences. I know as a Black woman, I've had to advocate. I've had to learn about some of the things that have happened before me, and make sure that I'm standing in the gap so that way people have better access for tomorrow. We have a really great group of panelists that are going to be here today that are going to be talking about what it looks like to restore trust on both ends, because we know it's not just on the onus of the community to know how to advocate, but how can we make sure the system honors what communities of color have been through, and how we can come together to make sure we can promote health for all of us for a healthy future. So again, James, thank you so much for partnering with us. I can't wait to sit back and listen to the conversation. Of course, everyone, if you have questions, feel free to, you know what to do with Java and with Jimmy. Put them in the comments of the chat, and we'll be sure to incorporate them into nice conversation. And there'll be more from us, so we'll be definitely following up with resources on how you can continue this conversation with your friends and family and your community, and ways to stay connected with Vital Connections. So I'm going to stop there, so that way we can come together for what we came here for, which is tonight's Healthy Java Vital edition, which I really like.
Mhm.
This is not the last. So I will pass it back off to James, and thank you so much for having us.
Absolutely. And I need to give you some flowers as well. I love seeing you budding, flowers budding. I love seeing you in this space, and really putting all your gifts and talents to work. And they were, going to work in other spaces, but this space is one that is vital, to the
Yes.
connections needed to produce health equity and a lot of things that impact our quality of life. So I'm glad to have you here. We'll let you go ahead and be in the background and do what you do there in the background, keeping us in line in this community
Yes.
partnership. And so thank you so much for being here. Ayana, I definitely appreciate you. We are getting ready to introduce our panelists. Our panelists this evening, I'm saving one for last because he is definitely a very familiar face, and I have to say is the foundation in what we know as your healthy Java. And so I believe I've shared the screen with one of my other guests. I'm not sure if live on the show, but I'm going to go ahead and ask Dr. Clark to come in. She will introduce herself in just a second. And then we have a good friend and sister as well, Melissa Hector, from the Boston Public Health Commission. And then we have this wonderful person, AKA known as Dr. Betancourt, Dr. B. Good to see you in the building virtually this evening as well. And so, Dr. Clark, if you could start with just introducing yourself. And I'm going to go back to my old model and ask you after your introduction to describe the title in one word: Restoring Trust in Healthcare. Describe your response to that in just one word. Good evening.
Good evening. It's such a pleasure to be here. I just want to thank you, both Java with Jimmy and Vital Connections. It's just a pleasure to be in this space. And I know you mentioned, or Ayana mentioned, long COVID and in the introduction. And I appreciate all the work that you have done to really shine a light on that, to understand, what that looks like, and to make sure that we keep it in focus. So I appreciate everything that you have done in the space. And just, by way of introduction, so I'm Cheryl Clark. I am a physician. I'm a doc over at the Brigham and Women's Hospital, and I've been a physician here for many years. And I'm also the executive director and senior vice president at the Massachusetts League of Community Health Centers, Institute for Health Equity, Research, Evaluation, and Policy. And it's an important opportunity for us to be able to support the scholarship and the mission of community health centers that provide care for so many and that are the cornerstone of providing health equity, particularly in Massachusetts, but around the country. So thank you for having me. Very much looking forward to this conversation. And the word that I am going to use to describe all this is trustworthiness. And we can talk about that.
So you did well. It's one word. It sounds like more, but that was good, Dr. Clark. That was good. Okay. Melissa, friend and sister, good to see you in the room. Probably just coming off a meeting or something and just so busy and really ensuring that, like others here, that we are doing well in the public health space. So salute to you and all that you do over there at the Health Commission. And shout out to our good friend, Dr. Ojakutu. Please introduce yourself and the same response after your introduction. One word.
Yes, thank you, Jimmy, and hi, Dr. Clark and Dr. Bencourt. So good to see you. It's been a while. It feels like eons ago, but it was only a couple of years ago when we were in the midst of the pandemic together.
Mhm.
Um, so good evening, everyone. My name is Melissa, and I have the honor and privilege of serving at the Boston Public Health Commission under the direction of Dr. Bisola Ojikutu. I serve as the Director of Equitable and Strategic Initiatives in the Executive Office, and I oversee our COVID-19 community engagement response work, as well as some of our high-level social impact projects, and also working on our internal and external relationships, to name a few. And if I had to sum up what does trust or mistrust in the healthcare look like in one word, I would say relationship.
That was good. Okay, so far we have trustworthiness, which is one word. Y'all coming with these one words with multiple syllables. Okay, I see where y'all at this evening. And Dr. Betancourt just scratched his head, so I know he's about to come with like a 6-syllable medical term word.
Just one.
Just one. Dr. Betancourt, sir, it is so good to see you. Thank you so much for being a real foundational person in even having this space of your healthy Java. It's changing and we're recalibrating, but this partnership here would not happen without the work that you've done with us and in supporting us since 2021. So we really appreciate it, sir. Please, for those that don't know who you are, introduce yourself and give us that 15-syllable word that you're going to give
No,
us.
I'm going one syllable. So
Okay.
Jimmy, it's great to be with you, and this is in many ways this is a dream realized, right? From the day we met in Nubian Square to now. I mean, this is just so wonderful to see this trajectory, to see your connection, your art, your craft, your love for community. So it's just great to be here with you, and I will always, when you call, I will always be here for you. So thank you for all you've done for our communities, throughout the last few years, and all that you have left to do. And I want to say it's an honor and a privilege to be with Cheryl and Melissa. These are we are brothers and sisters in arms, and we care deeply about our community. And so, I spent the last 22 years in Boston. Still, I'm a primary care doctor at Mass General, 1/2 day a week. But I've I broadened my lens a bit as president of a place called the Commonwealth Fund, which is a foundation that was established actually by a woman in 1918 to really improve the welfare of humankind. And this foundation has had its roots in developing some of the first public health departments in the United States, first rural hospitals, first medical schools in urban areas, did a lot of the work for the Affordable Care Act that led to really covering millions of Americans. So I have the honor and privilege of having the opportunity to lead this organization. It's been about a year, and so really, really exciting, incredible team in New York and in DC. And our goal is quite simply affordable, high quality, equitable healthcare for everyone. That's what we are focused on, and that's why this opportunity was so exciting. So my heart is still in Boston. My heart is also here in New York, where I'm coming from. But my connection to community is real, and so it's great to be able to come here and share. And I'd say we share because we care, and we share because this is our calling. And so I always like to say that when we're on here, we may have a lot of fancy titles, and we worked hard and sacrificed a lot to get them, but we're here with our community because it's from the community whence we come. And so that sense of giving back is really, really important. And Jimmy, my one word for trust is love. I think for us to have in the caring professions that we're all in, I don't think we talk about love enough. We love our patients. I mean, it's our calling. It's what we do. We want to care for them in any and all ways, and we have to earn their trust, and we earn their trust through demonstrating love for them. And to me, that's what we're trying to do, is find that love, find that trustworthiness, find that relationship again. And so I'm excited. We're going to have a great conversation tonight, and I'm thankful for everybody who tunes in, and I'm just honored to be here.
Dr. Betancourt, that's not fair, because I can't mess with you that much with your 1-syllable word as far as love. I mean, okay, fine. So trustworthiness, relationships, and love are words that come into this space when we talk about trust in healthcare. Melissa, when you were giving your response, and I'm going to start this segment with you, you had used the word mistrust. And so for me, can you define by your lived experience, your professional experience, that term mistrust for you? What does it mean on a sort of maybe micro level, maybe touch on the macro, and then I'll come to Dr. Betancourt and maybe ask him to go a little bit deeper on the macro sort of level of mistrust. There's what I mean by, for the audience, micro, me, the individual, is the patient. I may have some mistrust, but me, the individual, as the patient, may have some mistrust because my awareness of the systems that may cause some distrust or history. And so, Melissa, loaded there, but I know you're more than well able.
Thank you. Thank you. I love that. And, in all honesty, Jimmy, I'm not sure if we can start with the micro without the macro. And I'm going to quote one of my favorite auditors, who we all are familiar with, is Michael Curry, Esquire, who I just love hearing and talking about inequities and really helping us to stay aligned as to why Black individuals of the immigrant community, communities of color, are experiencing poor health outcomes. And one thing that Michael Curry always states is that in order to understand why today health inequities exist, we have to understand the history of it. And so that's what I mean with the macro level. When we talk about medical mistrust, the nation has a history of generational circumstances that have created generational traumas within families and within individuals' lives, that even if you to this day had not experienced specific medical mistrust within yourself, you have a grandmother or a mother or a sister or a cousin or somebody who has. And so you carry that weight, that trauma with you, and almost in a way of creating sort of a barrier to being able to really experience what is fully offered to you, because you're sort of standing on your tippy toes of what may happen to me. When you are seeing forecasts or medias that is not always positive of the communities that you come from around medical mistreatment, you carry those same sort of mental traumas as well. And I think that is what really brews the mistrust that I see people who look like me, people in my community that are not having positive or great experiences and health outcomes. And so therefore, I am also a part of that pool. And I'd love to give one small story, if I may.
Go ahead.
I had the honor of authoring a chapter to a book with a former professor. The book is titled "This Era of Black Activism," and I authored the chapter 11 titled "Racism, Poverty, and Health, Oh My." And I interviewed several folks, and one of the folks I interviewed was my father, who I love a lot. I'm a daddy's girl, and my father is a huge historian and used to be the former president of the Grove Hall Board of Trade. And a lot of his activism came from a lot of the mistreatment that he received growing up. And one of the stories that my father shares that always stays with me is this happened in the 1940s. So my father's 84 years old, but it's happened in the 1940s. And he said he was climbing up in a tree right here in Roxbury on Savin Street, and he fell from that branch and broke his arm. The ambulance came to pick him up and brought him to a hospital. He says he remembers waking up in what looks like an amphitheater, and he said he saw a sea of white individuals that looked like students. They were taking notes. He tried to get up, and then he fell back asleep. And so what I take away when I hear that story is sort of an onset of studies or experimentation. There was no consent form that was signed. There was no wherewithal on the realms of the rights to his body and being subjected to a study. And so we when we hear about the subjugation of being a part of treatments, of being a part of tests, it creates that broken relationship and doesn't allow that trust to be had when we're working with a practitioner and a patient. Now there's years and years and generations of that. And unfortunately, it creates what we see today is a disconnect when we should be a part of focus groups and testing and treatments and things of that nature. Black and brown individuals are often left out because of that generational traumatic experiences that many of our relatives have gone through, where we think that we're subjected in a negative way that's going to poorly affect us.
Melissa, I told Dr. Clark in the beginning that, we have an outline, but my response is based on your response. And so there's so much to unpack there. Thank you for sort of purposely demonstrating something that I often say, that in the realm of we can chew gum and walk at the same time, meaning that we can address the micro and the macro as well. And so thank you for sort of kind of alluding to the fact that you can't really talk one without the other. And so Dr. B, based on what Melissa said, and that sort of just thing of what I just said, you can't talk micro without macro when it comes to trust or medical mistrust. What are your thoughts there? You move heavily in the, you're in academic medicine. There's changes going on with trainees. There's new generation coming up post George Floyd and things. Where are we with addressing the trust and mistrust at whatever level you would like to speak to?
Yeah, so I've been a doctor now for some 25 years, and I think during our training, you learn some basic things, right? Number one, there's a power dynamic between you and the patient. So I'm gonna talk individually, and that power imbalance is manifests in a lot of ways, but the power imbalance is also a knowledge imbalance. This idea that one person has power because they have knowledge, and with that knowledge comes the expectation and the ethics that they are going to do everything they can to give you truth. And you then need to be able to believe that truth to take certain actions for your health, right? And so this notion of building trust and earning trust, really foundational to that is yes, the word Melissa used, relationship. It's to build that relationship. It's to create that bond such that you could share information that you have spent years learning that will benefit that person in front of you, right? Now, those are the fundamentals. It's almost the definition of trust, the ability to have reliable information that you can believe. And I think in healthcare, in these very intimate environments, life or death, clearly people are looking to that person with knowledge who's supposed to be caring for them, and they are starving for that trust, right? Wanting to be able to believe, understand, and potentially take action on what this person is saying. And to Melissa's point, we can't look at the micro without the macro, because in an ideal world, all healthcare professionals would do everything they can to earn that trust and to be trustworthy, going to Cheryl's word, right? But the history, I think, has led us to a place where we have been untrustworthy, unethical as a profession, have through medical experimentation, racism, segregation, in many, many ways, abdicated our responsibility, ethical and otherwise, to have people simply believe what we say on the face of it, on just meeting me and saying, okay, this is a doctor, so I should trust him. Quite the opposite. Many communities say, this is a doctor, I don't think I could trust him. It's like mistrust is the default. And so, fundamentally, I think what we've tried to do over time is to really understand that. And to your point, there's plenty of examples of, I trust my doctor, but I don't trust the healthcare system. I trust my state rep, I don't trust government. So there is this dichotomy here. And what that dichotomy demonstrates is that those individuals who are closer to you, if they invest in kind of building that trust, they can earn your trust in the midst of a lot of mistrust that they might have that's very, very well earned. And so I think that this conversation really is one that says, we've known about mistrust for a long time. It's well earned, particularly in communities of color. I would argue that healthcare providers speaking at a very high level of language also adds to that mistrust, no matter who you are. And that health literacy gap further, kind of creates that knowledge imbalance, if you will. But today, what we're faced with, especially, with our murder of George Floyd, the racial reckoning, is an ability to really understand this in very deep ways. And through the pandemic, we try to fight through it and say, we're worried because we're entering a situation where we're going to be leveraging a vaccine that people are going to be hesitant about in general, but communities who are mistrustful are going to be really hesitant about. So we went through all this together. I think what we've learned is it really is about being on the ground. It is demonstrating love, compassion, empathy, understanding. That humanity is what earns trust. But through our training, we've learned that we have to do a lot. If you really care about building trust, you have to do the work, and you have to do the work with that individual. And I think that's part of this journey. That's part of this conversation that we'll get to. I think that's kind of the story arc for me as I think about, mistrust and building trust.
Dr. B, thank you, and you too. When I stutter, it's a struggle. I'm doing well to just stay focused within what we want to focus and talk about. And so, Dr. Clark, I would like to ask you to build upon what both of your other guests have said, but then I want to ask you, and Dr. Betancourt, it's a good segue into something that you said that I would ask Dr. Clark to sort of wrap up this part of the conversation. Is by default, there is mistrust in a lot of a good large portion of Black and brown communities. If you could end on, what are the consequences? Dr. Betancourt alluded to the vaccination where, and it's funny, I put a post while it just really hit me. We're coming up on the anniversary of COVID.
That's right.
So many people are getting ready to relive the consequences and that default to which Dr. Betancourt spoke. What we saw, some of the consequences, but if you could just speak to that piece there, and please forgive me.
No, I'm with you. One of the things I should, that I'm also experiencing right now as we talk. So, I'm a doc, right? I'm a hospitalist. And that was us, right? So we were on the front lines of COVID when it first hit. I just luck of the draw. I was one of the hospitalists who was on that April in Massachusetts when coronavirus hit its peak, and we saw what was happening. And Melissa and Joe, and I want to really call out Joe. Healthcare, you talk about consequences, completely unprepared for what happened in terms of being able to take care of people across language. It's hard enough when you're in these systems that are really shaped by structural racism, that don't have good access to language services. It's hard enough to take care of people, when you can touch them and you can see what's going on. But at the beginning of the COVID pandemic, we often weren't able to even unmask and be in front of people, much less have those kind of relationships, that touch. And it was folks like Melissa and folks like Joe Betancourt in particular who helped us to stand up the services that we needed. And so the consequences, you talk about that. We know the disproportionate deaths from COVID, but this is a long-standing thing, right? It's heart disease, it's diabetes, it's all the things that come from that. So those are consequences. But I'm going to tell you something that I think the problem is not mistrust or medical mistrust. And I want to get your thinking on this too. When you say, and framing is important, medical mistrust, you are putting the responsibility on the micro, on the person. People are not responsible for the fact that our healthcare systems were established under Plessy versus Ferguson, right? Where there were no rights that African Americans had that anybody needed to respect. That it took people, and this is 2024 now, this is the 60th anniversary of Freedom Summer, where Black doctors and others took care of civil rights activists who could not get care in Mississippi and the South because of their race and ethnicity. And they did all that work that then that led to the establishment of community health centers. So the issue here isn't the individual's lack of trust. It's the fact that we as physicians, as people who are in health services, people who are payers, need to put the infrastructure in place to be human, to be loving, to make sure that we have the systems that take care of people so that Melissa is not trying to understand, like, where's the data? How do I even know how COVID and now long COVID and other diseases are impacting the people that I love and care about in public health settings? That as Joe has done his work as a physician and now is in a position to sponsor and to provide resources for organizations, how do you sort of put all that together? And I don't know if I'm going to get another chance. I'm just going to say thank you right now. Joseph is like Dr. Betancourt, the man who has vision around this work. And even just personally, not only were you there for us doctors when we were on the front line, but you also just personally supported a lot of the work that we've been doing to tell our stories. Because the other real consequence of this is if you focus on the mistrust and not the trust, but also if you don't tell our stories around how we overcome that, the structures that we do build, like community health centers that provide that care, if you don't talk about the investments and the ways that it has been centuries of contributions to science that people across the globe have made. Even the science around vaccination and inoculation, that's the very principle of the mRNA vaccines, or at least that thought. That was an enslaved man in Boston, Massachusetts, called him Onismus. We talk about that when we talk to people about the vaccination. So that's why I say it's not mistrust that's the problem. We need to put the onus and the responsibility on our systems to be trustworthy. And we also need to tell our stories so that we raise our assets. We talk about how we build, how we overcome. Those are the things that I think are important to focus on.
Dr. Clark, you just set context, set the agenda for the rest of this conversation. You did ask for thoughts. I'm going to provide some at the end, but I would like to ask a couple of things there. One is I want to ask you in the audience, Dr. Betancourt, and I think Melissa knows because they were out there supporting and funding me early on, started in COVID. And so this time of year, I'm hypersensitive. And so it just in real time just hit me that, this is happening. And so just to the audience and Vital Connections, please forgive me. Dr. Betancourt, I want to ask you because Dr. Clark said she wanted to hear our thoughts. So let's go there. Thank you, Dr. Clark, for setting context. Words matter. Framing matters. Changing the narratives and the cultural norm and lingo within these systems begins to change the paradigm that we need to shift. And so, Dr. Betancourt, your thoughts to what Dr. Clark just said as far as that terminology and medical mistrust does put the ownership, similar to now we say died by suicide versus committed. You know what I mean? It puts the responsibility back on the system. Dr. Betancourt, Melissa will come to you. And then I want to get into that point. Dr. Clark, you might as well have been the co-host tonight. What are the assets? What is the good that is going on that we are doing, that you all are doing to build the trust back within the medical system? Dr. B.
Yeah, I mean, Cheryl's spot on. I mean, I think part of the way we learn is understanding that people's perception is their reality. Some of the challenge with trust is that, you in the caregiving space or in institutions, you assume that trust exists. And so you operate from a framework that is sensitive when you hear something to the contrary from what you believe. So what do I mean by that? Countless medical encounters by healthcare professionals happen every day. And, you have a healthcare provider who maybe has great intentions and maybe recommends that you take this blood pressure pill and coming from a good place. And the patient then, well, I don't know if I want to take, they react in a certain way. And the provider, in that moment is like, well, why are you, I'm trying to help you. Why are you coming at me this way? Like, why are you, and so it creates this kind of disengagement on both parties, right? And part of it when we get back to the onus of whose responsibility it is, a lot of my work in my early years on this topic of cross-cultural education is around trust. It was around trust and understanding that, research tells us that minorities are more likely to feel like they've been treated unfairly in the healthcare system in the past based on their race, ethnicity, and more concerned about being treated unfairly in the future based on their race, ethnicity. So when that patient comes in to see you, mistrust is in the air. And if you don't understand that, instead you're going to react in a defensive way instead of saying something like, as you're talking to a patient, hey, a lot of patients have bad experiences. Do you have one you'd like to share? Oh boy, my last doctor, they used to do all these tests, but they never give me the results, and I don't know why, right? And in that moment, what you've identified is, yes, there's concern. We'll call it a concern. And that's an opportunity for you to do a couple of things. Apologize. Say, I'm sorry that happened to you. And I can't explain it, but I'm sorry. Number two, my goal here is to earn your trust. And so I'm going to do my best to give you information in a way that you can understand. And then hopefully you can believe in me. And if you don't, you let me know. And if I fall short, you let me know. But we're on this journey together. And I know this exists, but I'm here for you. And I'm here to try to earn that trust, right? So, this concept of understanding it's real, apologizing, even though it's not on you, but understanding that mistrust is in that room, not getting defensive, and instead going the extra mile to change that power dynamic, to set yourself back with humility and say, my job is in service of you. And so if I am in service of you, you believing me is the only way I could serve you well, right? So I think a lot of what we're talking about, organizations, individuals, micro, is about humility, is about real care, and is about acknowledging realities that then I think put a responsibility on you to earn that trust, not just to assume the trust is there.
Dr. B, thank you. And again, a lot to unpack there. It's so interesting. I'm listening to you, and because I worked in the medical industry, I've been familiar with good, bad, and ugly. And some of what you said is just a term we don't hear too much anymore because of capitalism and the almighty dollar seeping itself into healthcare. You got to get the patients in and out. So we don't hear this term a bedside manner too much anymore. And so some of that is, you talk about love and humanity. And so I'll stay away from my commentary. Melissa, your thoughts on the point that Dr. Clark made in reference to the fact of ownership. And this is a good segue maybe to getting in to talk about assets. I'm familiar with what the commission does. So maybe you can end with some of what the commission is doing around addressing building trust back in the system. But the point that she made around the system needing to do better for us to have more trust in them. Long way, but a different way and better way of framing it. Your thoughts there to what she said.
I mean, for starters, I love it. And I just always appreciate it when we can bring in the piece of accountability into the space. And so I've been working in human services and public health for last 15 years and consider myself an equity practitioner and a public servant. And I share that to say that wearing that hat as a public servant and an equity practitioner, as Dr. Bentoncourt just mentioned, I share that with humbleness and humility, because it takes a certain level of empathy and accountability to be able to understand what the direct needs are of the community in a way that is not forthtelling and sort of forthtelling in a way to say, this is what you need in order to continue surviving, continue living. As a person with lived experience with the majority of the constituents that we serve, I'm able to understand from an empathetic way, but as the public servant that's sort of back behind like policy and procedure, I then have to be and serve as an internal advocate, if you will, in the systems to be able to work with other colleagues and individuals to be mission driven to achieve the outcomes that we have. And so I think all of those things are key recipes for institutions to be able to be more accountable and take the ownership of creating systems, rewriting policies, and rethinking procedures that are going to absolutely serve and support individuals in ways that that are critical to helping to advance health outcomes. When we're talking about in the light of COVID-19 and the pandemic, one of the things that the city did that I think was really crucial was setting up task force that were comprised of individuals, elected officials, medical physicians, and that's where Dr. Betancourt and I got the chance to meet under the direction of former Mayor Marty Walsh, and I served under Chief Marty Martinez on the Health Inequities Task Force, was designed and created to steer the city in a direction that was going to make sure that resources were driven into neighborhoods that were most impacted. And we don't have to sort of second guess what those neighborhoods are, but I'm going to say them anyway. We talk about Roxbury, Mattapan, Dorchester, East Boston, all of our predominantly Black and Latino neighborhoods that were severely impacted with individuals who couldn't take time off from work, with individuals who did have what people learned as comorbidities, as diabetes or heart disease or asthma, that highly impacted being infected to another severity or having cancer, things of that nature. And so there were many things down to the basic needs of even having Wi-Fi connection in homes that many individuals needed that did not have. That was a surprise to many people. But these are things that we already knew people were experiencing, struggling on a day-to-day basis. And so institutions, in a sense, you have to wake up and realize what are people experiencing. Here we have the city of Boston, one of the most innovative cities, one of the most cities that show a lot of being the number one at creating a lot of many things. I mean, if you think of it, even Dr. Rebecca Lee Crumpler was the first Black female medical physician in the nation to receive a medical doctorate at the New England Female College, now known today as Boston University's medical school, received a medical doctorate right here in Boston. And yet we have so many ways of catching up to closing health disparities and health income gaps. And so that starts with the institutions. You know, after the Tuskegee experiment, vaccines were taken out of the hands of government and put into medical institutions to help sort of dismantle that differential treatment. And so it is on the accountability of still government institutions to be able to show up and utilize resources in an effective way, right? Like effective meaning like, are they getting to the people that actually need them? And then working with community-based organizations, nonprofit organizations to help steer those resources in the right direction. And then for medical institutions to be able to be just as mission driven in a way that's going to create language access, in a way that's going to be able to garner more medical physicians that look like the people that they're serving and be accountable in those ways.
And I've been known for doing this before, especially in this space. I almost said Dr. Hector, and doctors are not just in medicine. You better go ahead and get that in public health administration or masters in public health and then doctorate. You already got the masters already. So yes, I'm sorry. So we're getting ready to take questions from the audience if you have any questions for our guest this evening. But I'm going to start this segment. Dr. Clark, with you, I know of the work that you do with my good friend and brother. I almost called him Dr. Curry, Michael Curry. We're in the he's going to get me, but we're in the process now of reaching out because we want to pull him into a conversation in Boston Public Market around nutrition and equity and whatnot. So he'll probably send me a text later. But you all are doing great work there, and thank you. So let me go back to your last segment. You dropped a whole bunch of history there. You and Melissa named, and I remember off the top of my head, I'm not sure if Dr. B did as well, but as this being Black History Month, you named not only Black folks that did stuff, but Black folks that did it right here in Boston. You know what I mean? And so we have to keep at the forefront of Black and brown people's contribution for the medical industry in the past and in the present right here. What is your organization and you doing to address systems, structures? I know presumably all of you aware of the Health Equity Compact. There's things like that. And so can we get ready to not end, but this portion before we take questions, and sort of what are the assets when it comes to building trust, when it comes to, oh God, how do we frame it now based on what you said, when it comes to the medical industry regaining the trust of the community?
Yeah, being worthy.
Okay.
You know, I'm actually going to say too that he is Dr. Curry now. You know, Michael Curry does have an honorary doctorate, so he's Dr. Curry. I don't, you know, and I'm not going to speak for him. Yeah. So Michael Curry has his doctorate. You know, it's funny. When we have these conversations about letters and all that stuff, I think about my my mother. And I just like how like our doctorate is like from Loomis Street, you know, like where we grew up, you know. So sometimes the most important, you know, training and letters that you get is what you understand and your resiliency. And, you know, if I had to say it, you know, it's just, we just need to believe in people, you know, and we need to set policy that believes in people. I'm just thinking, you know, some of the things that Melissa was raising, you know, Joe was raising, just like, how do you make sure that you've got, you know, healthcare institutions where the people inside of the institutions look at the person in front of them, hear, you know, what they're saying and believe them, you know, just listen to them, you know, sort of, and then to make those actions where you build, you know, public health and medical systems that are designed to take care of people. So you asked me kind of what we do, and I'm going to give you two answers. The Mass League of Community Health Centers and the Institute for Health Equity Research and Evaluation and Policy, where I work and where I lead, we are in service of what are called the community health center movement, or the community health centers. And a lot of people now are hearing this term. It's called social determinants of health, where it's not just the medical care that you give, like the drugs and that sort of thing, but you also have to think about, you know, whether or not that person, you know, has access to a healthy, safe place to live, you know, environments that are safe, whether the food in the environment is healthy. Do you have to drive a lot of places to greet it? And even more structural things, you know, like how are we thinking about making sure that we all have equal access to educational opportunities, that kind of thing. So it sounds really new, right? Health centers have been doing that for decades, for more than for almost 60 years. It'll be next year, which will be the 60th anniversary. And what our organization does is to act in support of. So when you talk about assets, one of the words that Joe mentioned is humility. And you have to have the humility to know that organizations, community organizations, and patients, they know. You know, we have that knowledge, we have that information. And so we build our services with community needs in mind. If we have community organizations that are strong partners of the work, if we locate our health centers in local communities, that's what we mean when we say assets. We believe people. We invest and put the information that and the resources where the lived experience is. And I think it might even be on this page. It's called emancipatory action or emancipatory research. And we will talk about this because there's so many anniversaries that are coming this year. I hope you'll have me back for Juneteenth so we can kind of tie some of the history into that. But one of the things to really think about is this idea of making sure that when we are putting our resources in place, we are actually trying to solve problems. We are actually trying to move the needle forward. That's what we're talking about, assets. I'm going to end on one other thing, just how important it is as we are imagining and envisioning this to tell our stories. So I'm going to embarrass him. Dr. Betancourt has a portfolio called Changing Mindsets, and I am so grateful. Dr. Betancourt has funded our work called Shaping the Narrative. so that we can uplift and elevate our stories. So that when you learn about what it takes to be a doctor, you talk about Dr. Robert Smith, who helped to take care of people when they were fighting to vote. You learn about, Dr. Aaron Shirley, who built an entire medical mall to help address those social determinants. Jasmine Chapman, just really bright, brilliant dentist sister. And then you learn about John Hatch, who did community organizing before that was even a thing within healthcare. So part of it, I'm just going to end with that. Thank you, Dr. Betancourt, for funding that work. It's called ourhealthstories.net. You can go to that page. Thank you for everybody for supporting the work that we're doing at the Institute. But that's what we mean. You got to believe in people, and you got to have policy that does the same.
Okay. Melissa,
Yes.
I'm going to stay focused. Melissa, your closing remarks and on that. Well, I can name a few myself, but some of the work that the commission is doing and investing in, Melissa and I are going to be dropping a wonderful project come April. I'm trying to find a video so I can tease it real quick, but go ahead, Melissa.
Yes, yeah. So I'll share on my work, but I also just want to highlight, the Boston Public Health Commission is a 1,300 plus staff organization with 6 bureaus that do amazing work that focus on the holistic perspective of the individual, from environmental health to maternal health, paternal health. And there's a lot of different resources that each of our programs and bureaus do to help support our residents in many different avenues. At the executive level, one of the things that we're trying to be better at and that we're doing now is looking at how we can support our smaller community-based nonprofit organizations that do not have sort of like large staff or fancy grant writers, in helping them to have resources to do a lot of the direct service. And so last year, Dr. Basolo Jakuta and I created the Community Health Equity Empowerment Fund. And we are so thankful we received some support working with Dr. Elsie Tavares at Mass General Brigham. And we were able to fund 10 smaller nonprofit organizations that are doing health equity, acute health equity impact work across Roxbury, Mattapan, Dorchester, East Boston neighborhoods. And we're looking at other ways to create more sustainable resources in this way. In the pandemic, we were doing a lot more smaller one-time funding opportunities, and we want to make sure that people have sort of this residual support. And so that's one of the many ways that we are looking at continue having assets. We're also taking a really deep dive at our Health of Boston data reports. So those who may not be familiar with the Health of Boston, it's a culmination of reports that's released every 3 years. And the latest one was released last year in 2023. And it includes information on what we see are some of the most top poor health outcomes of Boston residents. And part of doing this report is so that, to Dr. Clark's earlier point, we can see how we, as a Board of Health, can be more accountable in the gaps, in the areas that are being missed, but also how we can share this data and information to our other colleagues and other institutions to create better ways in having resources. And so in the Health of Boston 2023 data reports, we saw a lot of health outcome disparities among cancer rates, particularly for Black men and Black women, among heart disease, maternal child infant mortality rates. And then, as many of you have seen in the news, a lot, the life expectancy rates among particular neighborhoods, particularly when we look at Roxbury and Back Bay, we are seeing a 23-year gap difference in life outcomes, life expectancy. And so what we're doing is we've gone on what we've called a community roadshow and have held Health of Boston community meetings in the neighborhoods that we're seeing these health disparities in, and we're working with the CDCs in each neighborhood, the community health centers in each neighborhood, to bring out residents, not just like-minded other professionals, but true actual residents, to share what is going on in these data reports. And we've also have brought on other community-based organizations to sort of exhibit hall and table and provide real-time signups and services in place. And so that's ongoing. And we're also working on larger communications campaigns to be able to just get more information out so that people feel more comfortable knowing how they can access and get connected to better healthcare or better resources to improve their health outcomes. And then just in summary, I just would like to sort of land on thinking about, Dr. Clark mentioned this earlier, and I was just talking about this with our Chief Behavioral Health Officer, Dr. Kevin Simon, yesterday.
My God.
Love Dr. Simon. And thinking about, Black and Brown individuals, because of racisms and discrimination, face a lot of our stories are traumatic. And so thinking about how we can turn our trauma into empowerment, how do we change sort of our narratives to continue to create and propel just rejuvenation and forward thinking and positiveness so that we can dismantle barriers or just mental barriers or other, leaning on other past experiences that may continue to hold one back. And so as we think about dismantling mistrust, as we think about building relationship and feeling more trustworthiness, I call on our colleagues, our other equity practitioners and public servants, just to think about how we can continue to help support individuals, create stories of empowerment, create stories that change the narrative of trauma so that we can begin to heal communities and now use the resources. It's 2024 now, there are resources and tools in place. There are resources that can really help create a difference. One of my professors always says, #follow the money. The money is there. And so now we just need to find better ways to, let go of what happened and allow folks to elevate in their right. So
Melissa, thank you. And between you and Dr. Betancourt, I'll go ahead and this platform itself has been a beneficiary during COVID-19. And we're getting ready. Before we go, Melissa, I found a video. We're going to tease a little bit of some of the work that we focused on last year with our young people that was made possible and we haven't even tapped into, our young people and their trust in gaining the trust of the medical system, gaining the trust back of our young people. Got it right, Dr. Clark? Dr. Betancourt, your closing remarks, closing thoughts, and please talk about
you got it.
Wonderful things that you're doing.
Yeah, so I just say quickly, I'm going to just say three things. One is trust is about action, and action is about caring and humility, right? So we could talk a lot about trust, but trust is earned when you demonstrate genuine care and you have the humility to communicate and connect with people in a way that relationship can evolve. I'd say that's important. I'd say second, I want to everybody who's listening, I don't want the power to stay on kind of, it's just a healthcare system that needs to kind of do work to bridge this gap. If you're a patient and you're seeing a healthcare provider for the first time, we should say, hey, I know we're getting to know each other. It's really important for me to be able to trust my doctor. It's really important for me to be able to trust my doctor. Leave that space open. And the right answer is, I want you to trust me, right? Like, I think as patients, we have the right, the power is for us to say what's important to us. And trust is important to all of us. And as communities of color, I think we need to name it and say, I just want you to know, me being able to trust my caregiver is really, really important. And how that person responds will tell you a lot about whether that relationship can evolve. I guess the last thing I'd say is that, during COVID, I think the biggest challenge, and the one thing we haven't talked about is misinformation filling the gap, is that a lot of times healthcare providers went out there without the humility. You're going to get the vaccine and you're not going to get COVID. Well, it ended up not working out that way. Instead of saying, look, this is the best I know now, and I'm doing the best I can, and I'm hoping that this is going to do this, and some tests are showing this, but, we're going to learn this together, right? That humility, that is much better than saying that, having that hubris of saying something with certainty which healthcare is littered with examples of that over time, of things that we said, yeah, this, hormone replacement therapy for women is the right thing to do. We found that wasn't correct. There's been times throughout medical history where we've said things with a lot of certainty, with a lot of hubris that have been proven wrong. So in COVID, there was a lot of that. And a lot of people said, wait, you said this and now it's not this. You said this and now it's not that. At the time, what we needed to say was we're doing the best we can and we're learning as we go. We didn't say that. And so that created a lot of mistrust and a lot of room for misinformation or for, man, I got to lean on somebody else for information because what they're saying, they said something and then they're not being true. If we would have couched what we were doing in that humility and that reality, I think we would have been better off. At the Commonwealth Fund, our opportunity is to partner with incredible leaders like Cheryl to be able to tell these stories. And philanthropy, our biggest, I think our biggest goal is to leverage our dollars, which in our Advancing Health Equity is our biggest program, to move policy, to move practice, and to create leaders. Now, I'll end by saying that we named 3 people, Kevin, Simon, myself, Bisola Ojikutu. We're all beneficiaries of a program that the Commonwealth Fund created some 20 some odd years ago, the Commonwealth Fund Fellowship in Minority Health Policy. We all did that program, right? So we think about leadership development, we think about practice, we think about policy and how to move all those areas. And I think Cheryl gave a great example of work that we support that's really, really important. And it's a diverse portfolio, but that's the perch that we have to really leverage in philanthropy.
Dr. Betancourt, Cheryl isn't the only one that's an example of the Commonwealth Fund supporting.
That's right.
So his support transitioned from MGH over to the Commonwealth Fund as well. And so we do have some questions. Dr. Betancourt, Miss Teresa is saying hello to you. We do have some questions from the audience. And what I'll do is I'll just ask them and anybody can jump in and ask. Heidi Ivy is asking, as we continue to see this war on women's reproductive health, how do you make women feel comfortable? Wow, good question. I mean, we're okay in Massachusetts. Shout out to Governor Healy. But who would like to now, Dr. B, with all due respect, I'm gonna throw that to Dr. Cheryl.
I gotta point the right way. That's right.
Either one of you.
Yeah, I'm happy to just give a short. I saw this question in the chat and I loved it that I copied and pasted it down to bring it back to my core planning team. So happy to share this fun little secret. So the Health Commission, we are actually in the process of planning our first inaugural Empower Her Black Women's Health Conference. And I think that one of the smallest ways that we can do is create a platform and a space where Black women can come and feel safe asking questions such as this, but also seeing practitioners who look like us, OBGYNs, gynecologists, cardiologists, oncologists, who are Black women to help provide comfort in answering these questions like this, but also how to advocate as a patient in the room. Like Dr. Betancourt has given so many sort of smaller examples about how to just have a one-on-one conversation with your physician. And I never really realized how critical that is to really be an advocate for yourself in that space with your physician, asking and managing up in a way to your physician, because you often have this sort of mental ethos that like they're the expert, they're the person who runs this session, and that's it. And so we shy away from being able to ask these questions. So I think that just from a public service level, being able to have a little bit more of a community space, and that's what we're trying to do, is build community for Black women to be able to come and learn about what's going on with Black women's health, how to be able to have safer spaces to learn and build conversations like this and walk away with the resources and tools. Now we know everyone may not be able to come, but this is a smaller initiative that's leading to a larger women's health initiative to help empower women of color across the city to be able to feel more stronger and confident when it comes to these issues like reproductive health crises that we're facing today.
So what I just heard from Melissa was, once registration goes up, register. Y'all remember when we the city of Boston had the community engagement summit, and So when you see the Health Commission, Melissa, please make sure once you put it out, if it's not already out, make sure I have it, and I'll make sure I share it with the audience as well. Dr. Cheryl, is there any thought that you want to add there as well to what Melissa said?
Yes, and I apologize in advance. Let me know if you can't hear me. What I would say, yeah, having some bandwidth issues. But what I would say is this: we cannot decouple these issues around voting. You know, making sure that we create the context for health from women's reproductive care. And the other thing that I would say is the thing that we can all sort of do is just don't walk alone. I want to just mention a personal story. We know that not only is maternal health or mortality for Black women, or maternal deaths really for Black women, the highest in the country, but we also, Black women tend to have babies, that are born early, born small, and sometimes have health issues. And our income, doesn't necessarily protect us from any of that. And I can tell you that because I have two. They run around, like I got to get home actually a little bit to check on them and see what they're up to. But both I have two small children who were born early. And part of what you have to do is not walk alone. When I was 25 weeks pregnant, so you're supposed to try to carry your babies to 40 weeks, and this was not even, like a part of the way there, it became apparent that I was trying to go into labor. Went to my hospital, talk about, trustworthiness. And I think, it's clear what to do. People didn't know, and my friend came down. I'm going to say her name.
Dr. Cheryl, I'm going to, because I want to hear this.
She's in California now.
Dr. Cheryl,
I went to the hospital.
Dr. Cheryl, sign out and sign back in on that link and see if that, because I need to hear this clearly. So sign out and sign back in, please. Thank you. So we got a few questions in here, so I'm going to go on to them, but I want to come back to Dr. Cheryl once she comes back in. One of the other questions were from someone by screen name. So Michael, how can we support patients or families with language barriers? I know interpreters, but how can we guide them with someone to trust? There are so many changes in our community. Great question. Dr. B, I would give this to you as far as, because you treat patients.
Yeah, so, I think I've been doing a lot of work on this issue. So I'm originally from Puerto Rico. For those of you who don't know me, bilingual, take care of a lot of Spanish speakers. And so I've been doing a lot of work on language barriers. And in Spanish, the word for trust is confianza. Confío en ti, no confío en ti. Yep. So confiar is do I trust, right? And clearly, I think anything that gets in the way of good communication hampers trust, right? Because trust is in large part built on how well people are able to communicate, connect, and develop that relationship. And so, when you have a language barrier, I think it's challenging. Certainly, I think we've gotten a lot better. A lot of stories of kids being interpreters for their families, navigators for their families. Sadly, we still see that on occasion. But I think as a state, Massachusetts has invested heavily in regulations and resources to make sure that we're addressing language barriers. Technology's made it better. But quite frankly, there's no substitute, and I say this with a lot of humility, as a provider who speaks another language, to be able to communicate with a patient in their own language. And so there's a cultural understanding, there's a linguistic understanding. And so how do we help people? I think part of what we need to do is kind of the chicken and egg. We need to train more healthcare providers who speak different languages, who bring different lived experiences, so we can better meet that needs. Interpreters are a stopgap. I mean, they're an important kind of thing that we could use, and I think they're helpful. But at the end of the day, I think you cannot replace, a physician who speaks Haitian Creole, a physician who speaks Spanish, a physician who speaks another language, and that ability to connect with that patient, I think that's next level. And so, patients and families, I think certainly making sure that their language needs are never unmet in some way, shape, or form, but also can we connect them to providers, the few, albeit, that might speak their language and might have a cultural connection. I think that's important. And that certainly impacts trust. And there are a lot of changes in community. Communities are becoming more diverse, but that's all the more reason why we need to do better around diversity in the healthcare professions.
That's one thing I just want to cite, Dr. Betancourt, is that in Massachusetts, I remember from being in the industry, like it may sometimes have to wait, but the patient can make a determination, but you do have the right to request a medical interpreter. That is someone that speaks the language, but they also know how to properly translate, because sometimes a family member may even go into Dr. Betancourt, what I call Spanglish. The doctor said blah, 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 blah. They say it in Spanish and they can't interpret and that is so important on the decision making. So I want to make sure that people understand that if they speak another language, and I'm speaking English, so I don't know how much it's going to help, but you have a right to ask for a medical interpreter. Dr. Betancourt, please go ahead and say it in Spanish, since we talking about demonstrating it. Please, sir.
Confianza. No, lo que estaba diciendo es que las personas, pues sí, si tienen, que no pueden hablar inglés, pues tienen el derecho de pedir un intérprete. Eso es lo más importante. Así que es un derecho que tenemos en nuestro estado de Massachusetts, que es muy beneficioso, y para nosotros, pues cada paciente tiene ese derecho y tiene que saber que lo tiene que pedir.
Okay, Dr. Betancourt, that just I grew up in Pentecostalism, and hearing you speak Spanish and knowing what you're talking about, so I was like, okay, it almost felt like you was having a Pentecostal experience.
But right.
No, in all seriousness, Dr.
Speaking in tongues, that tongue's Spanish.
Yes, sir. And so every language just spoke that day. Let me stop. But we do have some more questions and some comments as well. Great discussion. And I'm hearing from Miss Teresa, or reading from Miss Teresa. She's saying the same skepticism holds true for diagnosis of ADHD in children. This is very good, especially with where we are going in this. We keep saying it, post-COVID, the impact of COVID. We really haven't seen it yet. This is a good one. Dr. B or Melissa, please chime in here.
Melissa.
Skepticism around how can a parent decipher the truth when they're being evaluated? And we know that similar to some quick to rush, sometimes medical diagnosis is made by the medical industry. We know that in certain spaces where you diagnose ADHD or whatever with childhood challenges like that, sometimes there's a rush to judgment. And so by your experience, I will say, and give Melissa some cover, she's not a provider. And so this is general information, Ms. Teresa, that Melissa is sharing with you.
Thank you for that disclaimer, Jimmy. Yeah. So, I actually received a lot of calls and questions like this throughout the COVID-19 pandemic, when a lot of folks were at home, and, obviously we're told to not go into hospitals as often because of the inundated volume that hospitals were experiencing. And so at the Mayor's Office of Health and Human Services, we received calls for individuals who were recently diagnosed with either bipolar disorder or some sort of behavioral health diagnosis, and weren't sure either how to take care of their children after that diagnosis or what was actually going on. And one of the things that we always recommended was reaching out to another physician, another primary care provider, to get a second opinion on that diagnosis. Just because you just never know what else may be discovered or what could have been missed in that diagnosis. One of the things that we're working on at the City of Boston, specifically with the Center for Behavioral Health and Wellness, is creating more of what we're calling mental health resource maps, heat maps, that show where folks can get access to behavioral health resources in the city in real time. We know that we've had unfortunate higher rates of suicide prevention. We know that we've had some also not good experiences with individuals that may have had to call on first emergency responses related to behavioral health circumstances. And so I think that there's an opportunity for folks to be able to just have more access to behavioral health resources in the city. And I think that the more healthcare providers can provide those resources to patients, the better we can all be in this together. But my first response would be to try to get a second opinion at another primary care office.
Melissa, thank you. I just want to acknowledge we were able, because Dr. Cheryl, you had us on a cliffhanger. Not, and I pray it's ends in a good way. But I just want to go back. We have one more question, but Dr. Clark, I want to ask you to finish your story, and I want to give folks some time back. Dr. B, I know that we're getting ready to get you off of here, because I know when you've been in front of the screen and stuff and doing stuff all day, we're going to, because I know. Sir, I know. And so Dr. Clark, please finish where we fell out was that I believe you said you were 25 and
25 weeks.
25 weeks. Go ahead, Dr. Clark.
What I'm going to say is this. So 25 weeks pregnant, right, with my first child. His name is Benjamin. He's running around. So it ends just fine. But we were talking about this issue of what do you do, for women's reproductive health?
Yes, to Heidi's question. Yep.
Right. So one thing is that we got to put the systems in place. We got to vote, we got to make sure that we put policies. But the other thing is we got to, when you're in those clinical sessions, is listen to people. Dr. Audra Meadows, she's in California, listened, and she heard me and she said, you got to come in. And they did all the other workup that she told them to do. And she got him to stay in there. He came out a little early, but fine. She saved my baby's life, Dr. Meadows. And so that's what we got to do for each other. That's what I was going to say. Thank you.
Thank you so much. And I'm glad to have you back. We have one more question. And because Dr. Clark, you had to get some tech, we're going to put this last one with you. And so Pastor Marion is asking, if you all have a patient that is not in the pharmaceutical treatments, are you allowed to recommend natural health care? And feel free to go in a little bit into osteopathic. I actually had a primary for a while. And yeah, it was my primary for a while was an osteopathic doctor. And it was interesting because I'd go in and want him to write a script for something if something was hurting. He was like, no, maybe you want to try. That relationship didn't last.
Yeah.
Go ahead, Dr. Clark. Hopefully nobody, Dr. B, you're not osteopathic, right? Okay. And Dr. Clark?
I know. Yeah. No, I train in allopathic medicine, but have great osteopathic colleagues. So I'm just going to say that, so absolutely. There's a lot of different.
He was good. He was good.
Yes, sir. So lots of different ways of covering. Pastor Marion, what I would say is this: you absolutely need to, in my opinion, have relationships with practitioners that you trust and that can work with you, around what you need. For example, high blood pressure, has medications that if you need to take them, maybe you need to take your medications, but you can also do a lot with your salt, with getting a healthy exercise if you can do it. So there are other things that might be labeled, natural health care that absolutely your doctor ought to be thinking about your holistic approach. I think the most important thing for me is making sure that the person who is giving you information is trained in the kind of advice that they are giving you, so that they know what they're doing and that their practice is based on something, evidence or science or something that you can put your faith in. But the most important thing is that somebody cares about you and they're going to see you through, and whatever discipline that they're practicing, they're going to be responsible.
Dr. Clark, thank you. I one of the things that I think will be, and I know this name, Heidi is talking about Dr. Carrion Gomez. I believe she was at Rox Comp for some years, if that's the doctor that I'm thinking of. Dr. Oh God, this is going back. And Pastor Marion says thank you to all of you, and to all of you all three of you that answered the questions. Thank you so much. We are getting ready to wrap up. This has been one of the most remarkable sort of health equity conversations that I have been able to have in a while. I thank all three of you for bringing your authenticity, your transparency, and your lived experience into this space. And Dr. Betancourt, I would be remiss if I did not say, in your last answer, you demonstrated what you said folks should be doing. You gave real life examples of where the medical industry has lost trust. And so I really appreciate all of you doing that. And I'm going to make a plug here. I got to do one thing before I let y'all go. Melissa and I, when we talk about some of the things that has been done by the Boston Public Health Commission, I just want you all to see just for a quick minute, because we have not been able to fully tap into our young people. And this is just a small excerpt of what we did in partnership with our young people last summer. So I'm just going to speed it up just a teeny bit so we can
to like kind of keep up with being on Zoom, because like you have other things going on. There are family members in your house, and sometimes like my mom would need some things and I would have to literally get out of my class or tell my teacher I have to close my camera, I can't be there, just so I could help my mom out because my mom's really sick. So like when it came to being in class, it wasn't really
connection with each other, but we couldn't hang out. Being inside the house a lot can really mess you up because you would want to like go have fun or like activities, but we really couldn't because we couldn't go outside. And so for me, it just made me like really antisocial because since the pandemic, I haven't been around people. So like when I get around people, I wouldn't know how to like express myself because I spent so much time inside the house, so I just got really comfortable with myself instead of like hanging out with other people.
That's just one example of, and we're releasing that this April to really hear from our young people. So that's just one example. Melissa, thank you so much. Dr. Betancourt, thank you so much for the support. Dr. Clark, we're going to figure out how our good friend Dr. Curry isn't. No, he's supportive in so many ways. And so I appreciate all of you being here. We're getting ready to bring our director of partnerships back in. We're going to allow our guests to get ready to go. We want you to stay on for a few minutes because we got to share some information with you. And we need you to help us by filling out a survey and give us we're talking about trust. We want you to trust us. So we want to hear your opinion about tonight. So we're going to go and do that. All three of you, thank you so much. Another plug, May 11th, save the date, the Joseph Betancourt Health Fair that the Boston Public Health Commission was president supported last year. We're going to have the Mass League there and some presidents this year, Dr. Clark. So thank all three of you for being here. And I look forward to seeing you all in community very soon. And I have to say this, my mom, how could I miss this comment earlier? And Dr. B, take this back with you all. My mother is always going to be a mother, but in the vein of what I'm about to say, she said refresher classes, but the last part is what stood out to me. And I want to end with this. Thank you. Thank you for all of you talked about what you did in COVID, but thank you for what you all do in meetings, in exam rooms, on Zooms, on phone calls, in consults, and all of that. Thank all three of you for what in policy for what all three of you do for our community. And Mama Java is looking out and saying y'all need to self-care and take care of yourselves as well. So thank all three of you so much.
Thank you.
We're getting ready to bring Ayana back in. This has been one of the most awesome conversations that we've had in the Your Healthy Java space. And we're getting ready to bring back Ayana. We're going to share the survey link with you. So, but we're going to debrief a little bit. Director Polk.
Yes, James the Java Jimmy. Espresso Hills. Yes. Oh gosh, what a good conversation. I'm so happy I could just sit back and just like sponge all of the great things that were talked about here. And I'm really happy with the questions that came from community members and our Java with Jimmy regulars. I know I watch from time to time. And
hold on. Dr. Clark ain't done yet. She came back. Hold on.
Okay, come on back.
Yes, ma'am. What did we forget?
No, we're all set.
Oh no. So and I didn't tell y'all, but sometimes in to do the switch, I have to kick y'all out. So it wasn't the tech this time. That was me.
We're all set.
Dr. Clark, thank you. Well, she popped up quick. Yeah, go ahead. Go ahead, ma'am. Go ahead.
Oh gosh, no, but just really happy that we had some great folks that we know have been doing the work around health equity here in Boston, and not just from a like a sterile clinical space. It's definitely heart work. right?
I love
This
how
is
you
hard
said not
work.
from a sterile clinic, just you know, like
Yeah.
a robot. Yeah, I love how you said that.
Yeah, because the reason why I love these community convos is because it brings health, the conversation about health to life. I know
Mm.
all of us think about as it was said earlier, that health is just there's such an aesthetic distance to like being healthy,
Yeah,
right? Because we think
yeah,
about our doctors and knowing all the terms and knowing what we need to do and knowing the historical context and feeling like there's a distance because we may not see ourselves in these spaces. We just see ourselves as recipients of whatever care that we're given. So I really appreciate seeing different people in different spaces, right? Whether it be the commission, whether it be Mass League, or whether it be looking at how we fund different creative
yeah,
opportunities,
yep.
right? It's all part of the ecosystem. And I know, for us at Vital Connections, we make sure that we're engaging all of these pieces because it takes all of us in order to really push the needle, if you will, about getting quality health solutions for us who deserve it, right? It's not just about it being equitable or accessible. We deserve it,
We
right?
deserve it.
Health is a right. It's because
Mm.
I know when not to get on my soapbox, but I
Go ahead,
think
go ahead.
about historically, all right, I'll step up really quick because I know I was talking to myself
In the
while the camera
background,
was
right? I
going,
know you was going like,
right?
y'all preach. Yeah, yeah, yeah.
Right. And I think about the fact that, and I'll in the moment center myself as an African American woman. I know I come from a lineage of people who have you health has been a survive for survival, right? It hasn't been to make sure that we're well and happy and thriving and in a joyful space, right? It's just to make sure that we live enough to get to the next day. And I think
Oh, that's good.
we deserve so much more, right? So I'm just happy that we're able to work together and create more spaces for us to have the first step to talk about the people who have now worked so hard to become decision makers
Mhm.
and risk takers, to make sure that we all can live the healthy future that we all deserve, right? So that was my major takeaway, and I love seeing just the intergenerational piece of this. I love Melissa and the work that she's done at BPHC, because I know I've worked side by side with her on a number of initiatives. But yeah, I just love it, right? And I think that this is how it starts, right?
Mm.
These conversations, and then the next step is how we come together to create these solutions. So I know, one, we definitely want to hear your feedback. Please fill out the survey that I put in the chat because
I
I
put it
know,
too. I
right?
put it in there too.
Right. So, we want to make sure that we are getting just some basic understanding about how you feel about tonight, because I know I'm going to talk to James um, and talk about how we can do more things, right? Because I know for us, stay tuned. We have our community health hubs where we work in the community and provide different opportunities, screenings, and things like that to make sure that we're meeting everyone where they are. So you don't feel like health is a bus or a train ride away, it's right in your neighborhood. And there's a number of different opportunities that I know that we have a number of partners that are coming together. I know again, I'm going to be talking to you, James,
Yes,
to
ma'am.
see how we can come together, because I know it's conversation is the first step, but action is going to take us all. So yes, fill out the survey. Just a couple quick questions about how you felt about tonight. Also, another thing I'm going to put in the chat. We have a community
Yes.
resource guide, and I know that we want to make sure that you all leave here empowered with information, because I think that that is the most important thing, right? Yes, these conversations have sparked your interest. So now that we know what the steps we need to take on all ends of the bridge on how to create this restorative relationship with our health, we want to make sure you have what you need in order to advocate and to have and continue this conversation, because we know that it's really important. I know James has it up on the screen. I know
Let's
I'm
just
going to
review
put it.
let's just
Hmm?
review some of the
Yeah.
bulk real quick. Before your healthcare appointment, make sure you have a complete list of your medications with you. My grandmother used to put all her medicine bottles in a Ziploc.
Hey,
Nana. Make sure you take your medications with you. Make a plan for remembering the conversation during your visit. These are actually in the link is in the comments, so you can get this for yourself. If your appointment is telemedicine, and this time, ensure that you have access to a phone and computer with good internet access. Ensure that you're in a private location. During your healthcare appointment, stay focused on why you were there. Be honest with you. That's one thing. My doctor, the good, bad, and ugly. I ain't always been a good boy, and I would always be 100% honest with my doctor. You have to be. Make sure you understand the next steps as far as the test and follow-up. Ask for an appointment summary. In these days of Epic and whatnot, you should be walking out, they point and click, and everything is right there, all of your information. After the healthcare appointment, track your appointments. If your doctor refers you for a follow-up appointment to a specialist, make sure that you book that appointment as soon as possible. Work with your healthcare professional, follow their instructions, call with any questions or clarifications, document your experiences, set goals with your health professionals, and also to our good friends over at We Got Us, there is an appointment empowerment kit that didn't pop up in the screen, but we're going to put the link. Ayana, you know we do the production engineering and whatnot right here in real time.
right.
We're going to put that in the link as well, where you can do your appointment and empowerment kit there. And shout out to the good brother over at oh God, I can't remember his name. He's going to kill me. Oh God, Kareem. Is it Kareem? What's his name?
Yeah,
Kareem.
I believe so.
Okay. All right. Hopefully he's not watching. Heidi. We said, so this is funny. We forgot to say this, Ayana. In the beginning, and what Vital Connections usually does is a more intimate space in Zoom. So sometimes people share their medical information. Heidi, I was going to say TMI. She said, ugh, I got to schedule my colonoscopy.
Hey, look, she shouted it out. Everybody has one. Do what you got to do in order to make sure you're good. So that's all right. That's all right.
Look, I got to schedule mine too. So, Lord Jesus. Okay, with that being said, Ayana, thank you so much.
Y'all got to check, right?
With us this evening. Don't forget in the comments, everyone. There are, Ayana put them in, I put them in. There is the resource guide as well as the survey. The resource guide is most important, but the survey is important as well, because that's going to tell us how can we talk about you giving input. Give us input on what you think about tonight. How about the equity and putting trust in Your Healthy Java, the Vital Edition, Part 2? Yes. Tell us and help us so we can make it better.
Vital Java. That's what I'm gonna call it. Vital Java. So see, that was off the dome. See.
I got to remember, we're not look, we're not on the phone or on FaceTime. So with that being said, AP Junior, get off of here. Thank you so much for everything that you do. I love the wonderful edition. We got to give some shout outs to Dr. Joseph, also Ariel, and I have to shout out our friend that supports both of us, Dr. Makiba McQuarrie, as well from the new. We got all type of Commonwealth. We got to get the Commonwealth funds together. The new Commonwealth Fund, the Commonwealth Fund. I just thought about something. AP, we'll talk.
Okay, we'll talk.
All right, I'm going to get you off of here so I can do my shit for the next couple of days of shows. But AP, thank you so much, and call on us, and we'll be in contact. And let Ariel know. She'll know what you mean when I say I'll take care of that tomorrow. She'll know. Thank you so much, hon.
All right. Take care, everyone. Thank you so much for having us again. So
absolutely, thank you. Bye-bye. Actually, no, you got to do it like this instead of saying good. What's the right way to do it? Where's the JJ?
Right here.
This
right
way.
Here.
Same as the hat. Yeah. Same as the hat. Okay, that's the JJ.
Okay,
all right. Listen, everyone. Bye. Give us your thoughts about tonight. Please make sure you fill out the survey. I also want to remind you that tomorrow morning at 9 a.m., I got to get ready to run out of here and go get ready for these folks. But I have the opportunity to speak with my sister and my brother. That is going to be Sheena Collier, also Dart Adams. We're going to share a conversation about Black Boston. Sheena is the president and founder of the CEO, whatever it is, founder and CEO of Boston While Black. And also Dart Adams is a journalist, researcher, and lecturer, and most known lately for his appearance in the documentary Murder in Boston. So please plan to join us tomorrow morning. They will be here in studio live with me. It's a whole different vibe when you're sitting next to someone. Then we're doing a special session this Friday, as we just got through talking about health equity. We did our session earlier about transportation equity. We're coming off Black History Month, and we are entering Women's History Month. I have the honor and privilege of bringing my sister friend into the Java Cafe again. She is no stranger. Congresswoman Ayanna Pressley. She represents us for the Mass 7th District here in Massachusetts. She's going to be with us on Friday at 9 a.m. So please plan to join us on Friday. That's it for me. I got to go out and get ready for tomorrow morning. So we'll see you guys tomorrow morning at 9 a.m. Please make sure you join us and have a great day, everybody. I think I got all my comments in here. Alexandra, thank you so much for being here. Michael, good night. Thank you for being here. So, Michael, thank you for being with us. Good luck with your training and everything you're doing. Sister Soraya, thank you. Ma said, I knew I liked Ayanna. All right, y'all have a good night, and we'll see you guys tomorrow morning at 9 a.m. Have a great day, y'all. Peace.